I consider it my duty to go to residencies, right, where family medicine residents are in training and tell them about this. You don't have to sign up with the big name hospital. There are other paths, and people are successful. This isn't some pipe dream. And the first time I gave a talk like that was down at Henry Ford Health in 2021, I believe it was. And a lot of confused faces and a lot of questions, really good questions, but clearly most had not heard about this practice model. Fast forward, I gave this lecture to a Corewell hospital in Grosse Pointe a few months ago, and a couple residents brought books from a local physician named Paul Thomas, who's written a book on launching a DPC practice. Two or three were like planning to go into DPC immediately following residency. So we're already seeing this paradigm shift in the training classes.
Hello, welcome to an episode of the Healthy Savings Podcast. I'm your host, Sasha Gribov. I'm the founder of Miu Health. We are joined today by Dr. Danny Seidman, who is a direct primary care physician and the founder of DHS Advisors. Danny, welcome aboard.
Thanks so much, Sasha. Nice to see you, and I'm happy to be here.
We're excited to have you. We haven't spoken with nearly as many physicians and clinicians on this podcast as I would have liked to. So I'm excited to have you on and to get into all things DPC and all things health plan, from a physician and physician advisor perspective. Maybe to kick things off, we usually just start by getting a background on you, who you are, what you've done, what you're doing now, how you got there. Do you want to give us a background?
Yeah, absolutely. And feel free to jump in with any questions. So born and raised in outside of Detroit, Michigan, trained in family medicine and did a fellowship in sports medicine. And from there, took what I thought was going to be my forever job. So I joined an academic practice in Northwest Detroit to teach residents about sports medicine, carved out a nice little niche, and had what I thought was a great contract coming out of training. And soon after that, figured out it was not going to be a great fit for me. We found out that most of what the patients needed was navigation, care coordination, money to buy food, things like that, education about the healthcare system. And also after a year and a half, my department chair came in, great guy, sat down with me and said, "You're doing great. If you want to keep making your salary, we need you to see 6 more patients a day and come in one weekend day a month and shorten your physicals. And if you do all that, you can not take a hit on your salary. And if you want to make more, you just see more people." And I didn't think the incentives were aligned properly and wasn't looking forward to cramming people in and not doing a good job. And that's what sent me searching for something new and came across a direct primary care company that was a startup in our area. And that's where I had spent the last almost 7 years now. I joined them. They had an on-site clinic at an employer, and I ran that for a few years. We grew throughout the pandemic, and DPC as a whole has continued to grow over the years. And I worked my way up to what was called the senior medical director, so overseeing 7, soon to be 8 employer and freestanding clinics for direct primary care in our Tri-County area.
That's awesome. How did that all function, kind of overseeing all those clinics, and how different was it between kind of the employer clinics versus the freestanding clinics? Like, how did you put all those pieces together?
Yeah, it's a great question. So interestingly enough, we had one on-site clinic. The rest were in the community. The community clinics were about 50-50 individuals and employers. So we would allow folks to sign up on our website. They could just click a link, fill out a form, and be a member. We also contracted with employers, not just for opening these on-site clinics, but they could take advantage of the network of clinics. So let's say you had an employer in the metro area, their people could choose one of 5 clinics, whatever is closest to home, or the doctor they thought they would get along with best. Some took care of kids, some didn't, so maybe you wanted to bring your family there. So the processes in place for those offices were similar, if not identical, for the employers outside of a couple, paperwork type items. The on-site clinic, totally a different beast. Stayed open 12 hours a day to meet the needs of the different shifts at the company. Much more high volume, a lot more urgent care seen there. A very different style of medicine and different needs. Each population has its own, needs and quirks. And so operations there were, for lack of a better term, a little more rigid, predictable, needed to be in order to keep things running smoothly.
how did you think about that world? Because they're kind of two different categories, right? On-site clinics versus DPC. Sometimes they're combined, sometimes they're not. How did you think about those two worlds, and how did you talk to employers about them? Like, are there some employers that one is kind of the no-brainer versus the other? Is a hybrid model oftentimes best for groups? How do you think about that?
Yeah, so I think it depends on the kind of sales channel or pipeline, whatever term you'd like to use for bringing that employer in. So sometimes the initial pitch to the C-suite is, come experience this yourself. So it's really more of the individual benefits. Come see what the care is like, experience having that personal doctor on call 24/7, the slower pace of the office, taking their time with you. So oftentimes that's the pitch. Now, during something like an RFP, we're talking more high level. How do we integrate with your health plan? What are the needs of your people, and what specific programs or interventions will we install to help your population succeed and be healthy?
Makes sense. Mm-hmm. And how big of a role does geography play? How have you seen virtual work or not work in the DPC space, and how important do you think like physical presence and location is in the DPC world?
Yeah, I think it's everything. And, as much as we talk about new technology and AI playing roles in modern day healthcare, healthcare is local, hyper-local, if you will. And I do think that you need to have that physical presence. You lose a lot without it. Are there things you can do virtually? Absolutely. On the first day of COVID, we pivoted from about 3% virtual care to 99% virtual care, which was nice. We're not billing insurance, so we were able to do that pretty quickly. But there are things like an ear infection. What's going on? Do you have wax blocking your ear and that's why it hurts, or do you have an ear infection? You cannot diagnose that virtually. However, it's a very cheap and easy thing to do in person and doesn't take a lot of time. And as a result, the patient gets the right treatment. You're not overutilizing antibiotics. And so there are a lot of situations, that's a basic one, but situations where the person needs to be seen in person. And additionally, you want it to be done by your primary doctor. So, seeing someone with continuity of care, seeing somebody who knows you, they can understand what things look like when you're healthy, what things look like when you're not healthy. Having that primary care doctor as your sole or primary provider, rather, for urgent care and primary care needs, I think is vital to get a good outcome.
I want to kind of go back to the experience that set you on this path of working in kind of the day-to-day traditional healthcare system. Have you seen that change at all in the past 7 years? Like anecdotally from your friends who are clinicians, do you hear the same thing? Do you hear from them that they're having more time with patients, less time with patients? Is burnout the same?
Yeah, it sounds like you might know a little bit about this already, but it's way worse. Things are getting way worse from what I understand. I haven't been employed by the hospital system in a long time, but the things that we're seeing on the macro scale, like hospital consolidation, private equity coming into play, things I think are worse than ever for the hospital employed doctors. And it's not to single out a single hospital or healthcare system. It's happening everywhere. Consolidation does not do good things, I think, for the frontline folks like us primary care docs. What I have heard and seen is that, not only are contracts more restrictive, there's covenants in them to prevent competition. People would have to move cities or move states to get another job. It's very common in healthcare, especially with physicians, to have very restrictive agreements. But they're also, asked to see people with several complicated conditions in a 15 or 20 minute slot, and people are late, people are early. You usually get on average about 7 minutes with the doctor in that setting, which is not enough. In DPC, we focus on 30 or 60 minute slots for things like that. In addition, just talking with some colleagues locally, won't mention the healthcare system, but they haven't had air conditioning in 6 months. The cleaning crew stopped coming to the office. An office manager was let go, and so now they have one office manager for 4 offices, so they split their time that way. And so all of these things that are done in the name of efficiency or consolidation are just really negatively affecting the primary care experience. And I think a lot of it, too, is decreasing insurance reimbursements in primary care. So, when you compared with inflation, I saw a stat recently that primary care docs are making like 30% less than they were 10 years ago. So the answer with the healthcare systems is volume-based. And that's one of the reasons why I think DPC is so good, not just for the patients, but also for the physicians.
That's crazy. It's funny. I think if I had a magic wand to wave over the U.S. healthcare system, that's one thing I would do fast. Like I would increase reimbursement for primary care dramatically. I don't know by what percent, but like I saw a stat recently that, I don't know, maybe I think it was Stanford's med school class, and the number of primary care or family medicine graduates was, I don't know if it was a zero or maybe folks who like intended to practice in primary care or family medicine was a zero, but it was something wild. And it makes sense, right? If you can make 5x, 8x more doing some of the specialties and have a lot more of your life and feel like you're having more patient impact because you're spending more time with people, it's a no-brainer, but like it just breaks our system.
No, it really does. And and I think, if I were to wave a magic wand, I'd do something similar. I think if every person on Medicare and Medicaid had a DPC doctor, the payment structures are really challenging to work out. We've had a few companies try and fail. But I think that would go, it would do so well for so many people, physician and patient alike.
Are you seeing more entrepreneurship amongst physicians? What I anecdotally hear, and I think it's right, is that 50 years ago, a huge percentage of doctors were entrepreneurs. They ran their own practices, and now it's impossible because of billing, consolidation, yada, yada, yada. That also hits my magic wand list. Like, what could you do to make that easier and frankly more lucrative for physicians to go out on their own? Are you like, you're a physician and an entrepreneur. We'll talk about that in a second, how you started your own thing. But like, do you see more of that happening?
We do. It's really exciting. So I think especially in primary care, it used to be specialty clinics were the only ones still private. But, I consider it my duty to go to residencies, right, where family medicine residents are in training and tell them about this. You don't have to sign up with the big name hospital. There are other paths and people are successful. This isn't some pipe dream. And the first time I gave a talk like that was down at Henry Ford Health in 2021, I believe it was. And a lot of confused faces and a lot of questions, really good questions, but clearly most had not heard about this practice model. Fast forward, I gave this lecture to a Corewell hospital in Grosse Pointe a few months ago, and a couple residents brought books from a local physician named Paul Thomas, who's written a book on launching a DPC practice. 2 or 3 were like planning to go into DPC immediately following residency. So we're already seeing this paradigm shift in the training classes, where they're maybe entering the primary care residency with a plan to launch their own practice. Again, that's how it was 40, 50 years ago, and then the world of hospital consolidation and buying up practices kind of ended that. Wasn't on my radar when I left training about 12 years ago, but it's coming back around. And I think there's been a 1,000% maybe increase in the amount of direct primary care practices over the last decade. So we're seeing explosive growth nationwide in that, and it's very exciting.
I didn't realize that number. Like that is explosive growth and it's amazing. How about on the employer side? Like when you were overseeing this group of DPC clinics, and I'm guessing you were also going to employers and talking to employers and bringing it in. What was the reaction that you got? And do you feel like most employers are getting there, or is it still honestly slow going?
Yeah, I would say that it's all over the map in terms of the reaction and the level of education on direct primary care. And I do think that companies really installing a version of direct primary care are still on maybe the late end of the early adopter phase. We still get a lot of questions, a lot of concern. There's always the folks that think we're like greedy for taking cash and not insurance, that don't really understand the financial implications and the dynamics of how that works. And also think that, well, how come you can't also take insurance? There's certain legal and logistical issues that come up when you're trying to do that, like a hybrid practice, as you mentioned. But I really think it's all over the map. Some come, because they heard about something cool in a DPC practice, like somebody got stitches on the weekend and didn't have to pay out of pocket. Or they had a family member enroll at a DPC and said, hey, this is great, you should do it for your company. And then all the way on the other end of the spectrum, we might be doing an RFP. We did one of these a few years ago where they already had a DPC on site. And they were concerned about the level of access, the quality of care, that sort of thing. And so we really are seeing it all over the spectrum. But I would say most still need an explanation of the concept. What is direct primary care?
Is it expensive? Like if you go talk to, I don't know, a 500-person employer, let's say they're a blue collar group. Like, is there a sticker shock with hey, this is what I'm going to have to pay to set up DPC?
It's funny. It all depends on your perspective. We say it's cheaper than a cell phone bill. The DPCs in our area for a corporate like that, if they're utilizing already existing offices, are in the realm of $70 to $90 per member per month, which is, it's cash, right? It's almost $100 a month. Some people think that's expensive, and some people cannot believe how good of a deal it is. Because a lot of it too depends on your interaction with the healthcare system. If we have a healthy executive in their 40s that goes to the doctor once a year, they tend not to see the value. But if you have somebody with a couple chronic conditions, they've had to battle the healthcare system to get what they need, and all of a sudden they have this private physician as a concierge service, they have some care navigation access, they don't have to wait for appointments, they're thrilled. They think that $80 a month is a bargain for this sort of thing. So it really depends on your perspective, but all over the map.
And how does it usually work? Is it like, does an employer buy it for the whole population and pay for the whole population? Or do they buy it and it's folks who sign up? And is it usually just for employees who like specifically go and elect to have this benefit or choose the DPC as their primary care physician? Or is it any of those options and it just varies?
Yeah, any of those options. Most, at least in my experience, will offer DPC as a standalone, so you can tack this thing on to any of our health plans. Up until last week, it was a challenge to do that with the high deductible health plan, but there's some great news that came through with that recent passing of the big beautiful bill, that allows folks to pay out of their HSA and get DPC as first dollar coverage. So that's a really exciting separate development. But the way we offer it typically is alongside a specific health plan. So let's say you have your PPO, your HMO, and then you have your DPC option. And I think that's a great way to do it because you carve out primary care, and that allows you to do some pretty amazing things like separate on the plan design, like lower copays, lower deductibles, cheap generic medications that tie in because we know that the DPC doctor is going to do the right thing in terms of care navigation. I've even seen, we didn't do this in practice, but other DPC practices have negotiated away prior authorization in their DPC plan, which also is a huge time saver for patients and for physician practices alike. The theory behind doing that is really, the way we like to describe it is related to car insurance, right? We all know health insurance isn't really health insurance, it's just what we call it. And for our cars, you would never think of like using your car insurance, calling that number to like fill up your gas tank or get new windshield wipers. These are cheap, predictable expenses, and so is primary care. And so we think that primary care, specifically DPC, should be this small, relatively small when you talk about healthcare dollars, monthly, predictable cash payment that covers most of what you need to consume in primary care.
When you go and set that up with an employer, and so basically I could get my standard, let's say it's PPO plans, not HSAs. I can get my standard PPO plan, or I could get my PPO with DPC. And then how does it usually work? Does the employer just kind of say, hey, I'm gonna pay for half of that DPC cost, and the employee would pay for the other half, and maybe it nets out because other stuff is cheaper in the plan?
Yeah, usually, the finances can get a little complicated, and then the employer also has to decide, are they going to use an HRA for this sort of thing? What does the software platform look like that figures out that transaction where a portion comes from the employer and a portion comes from the patient, and then how does all that money go to the DPC? And so what we've seen is more of usually it's an all or nothing where the employer will just pay the fee on behalf of the patient. They may give them a small copay just to have some like skin in the game. And the other thing that we've seen is that we have some concierge practices as well in our group. And so we'll see a company say, okay, we'll cover the DPC, and then if you want to sign up for one of the concierge practices at a higher price point, then the rest of that payment, you're responsible for the remainder basically. And we have a software platform that can handle that transaction.
I'd love to talk about your new endeavor, DHS Advisors. What is that? How did you How did you get into it? How's it going?
Sure. Well, yeah, all my years of experience doing these RFPs from the direct primary care side and speaking with employers, working through logistical issues with them, trying to design programs for the employer population, has really kind of opened my eyes to the shortfalls of the current system. I think a lot of times large employers, self-insured employers, have somebody in HR making decisions on their plan. A lot is done by the broker or advisor. There's a lot of gray area that we see in terms of where does the buck stop, who's responsible for the decision making. And a lot of employers simply don't have the transparency right now to look at their own data, especially on an individual level. There's a lot of HIPAA related concern, which you can, as long as you're not using the data for hiring and firing decisions, I think it's really important to look at the individual level data. You may have somebody spending, $1 million on a single drug, and you could really make an impact there. But yeah, so seeing all this over the last couple of years, I realized that these companies should have what I've been calling a fractional chief health plan officer. So who is a primary decision maker for the health plan? It's such a large spend. I think it deserves its own individual making those decisions and overseeing them. Somebody with the right combination of leadership experience with healthcare experience, understanding how the medical system works. And so that's how I have positioned myself. And I started this company, this consulting company, to talk to employers about utilizing DHS Advisors in this capacity. And I think especially with the new transparency laws, there's been several lawsuits about breach of fiduciary duty under ERISA. And so I think that there's really a need for this role. And it's going well so far. I think I'm learning, as I've read about and experienced in the past, that battling for data and battling, as you know, large part of what you guys do with me, Lou, I'm sure. It's a long game, and there are many barriers. Lots of, we'll get to that soon. I'm not sure. Let me follow up with you next week. These things get drawn out over many weeks and many months, so that's what we're battling right now. But officially signed my first client a few weeks ago, so that's been really exciting, actually kicking off a big project. I'm partnering with the Health Rosetta, who does a great job pursuing data transparency and designing these health plans. And so working with them, their data experts, compliance experts, it's been a whole world of education. I absolutely love it. It's super challenging work. But really my goal has always been to help people at scale. And I think this sort of work, if you can help an employer with 10,000 folks on their plan succeed, I mean, you're doing a lot of good for a lot of people. So that's my goal here.
That's awesome. Congratulations.
Thank you. Yeah, it's been a lot of fun. Very exciting.
I've heard Mark Cuban talk about companies needing their own healthcare CFOs, I think he calls it. But that really rung true to me. I think you need deep expertise to make both strategic decisions as well as to figure out, how do we piece all this together and how does it run? In our world at Milu, we kind of go, we don't do the strategic stuff at all. We go on the day to day, like this member just had an emergency room visit. Has anyone had a hospitalization? Has anyone talked to them about rehab options? This member has a chronic condition that's escalating, and we see it because we connect to the health records. Mm-hmm. But we're so much more powerful when there's a team on the other side working with us that has a medical mindset, that has a cost mindset, and that we can really partner with. And also when the plan's designed, to be able to do a lot of that kind of stuff. If it's just if it's a very vanilla plan design, I've got my standard big carrier. There's less stuff you can do. There's less money you can save. There's less steerage you can do. Less drug savings. All the typical issues. So there's a ton there that needs to happen.
Yeah, absolutely. And so that's my goal, is kind of opening employers' eyes to that possibility, right? Like a lot of folks we've talked to just don't have data, don't have individual data or actionable data. And that, puts all the really important work you guys do at Milu at a standstill, I would think, or at least significantly limits the impact you can have on the individual in a timely manner. We're really trying to get that data, access to that data. So I want to know when you hit the emergency room so we can do something. Intervene. And so, there's a million possibilities in terms of what you can do for folks once you have access to timely and accurate data.
Like if you think about the employer that you can have the most impact with, what's their profile? Blue collar, white collar, mix of both, size, priorities? Like, what do you think is the sweet spot?
Yeah, I think that's a great question. And so I think a lot of it is what you would think of as kind of a typical employer, maybe a blue collar sort of employer, in that it should be somebody who has some experience with self funding, or at least is large enough to go self funded, which in our area I think can be as low as maybe 100 folks on the plan. The more the better, the more leverage you have, but also localized. So the interventions that you can put in place and the amount of direct contracts you can pursue, for example, they're limited if you're a company with 500 people in 20 states. But if you do have a single headquarters, for example, even if people are spread out in maybe a tri-county area or a metro area, I think that would be ideal. So, anywhere from several hundred to several thousand team members on a plan, and if not at one location, at least localized. I'm thinking in our area, there's a lot of like tier one auto, where they maybe have 4 or 5 different locations in Metro Detroit, or somebody like a dealership network where maybe they have 10 Ford dealers in the state. So I think those types of businesses are really good candidates for this sort of thing. And you can, obviously, if there's a nationwide employer with tens of thousands of folks on the plan, there's a lot of interesting things you can do. At that point, though, it's not somebody who probably needs a fractional chief health plan officer. They're probably bringing a lot of this in-house. Their own, C-suite member who oversees, their own advisor, maybe designing their own plan, not using one of the carriers, but maybe their own transparent TPA. So at that point, you get to be of a certain scale where there's other needs, I think, bigger departments. So I would say in terms of the plans that I hope to work with, that probably tops off around 40 or 50,000 members.
What's your dream plan setup? Let's say you've got an employer that's in that target. Let's say they're blue collar, 10,000 employees across a few locations, relatively geographically, and connect maybe a few plants around the Midwest and a bunch in Detroit. And they've got a pretty traditional health plan now, PPO, HSA, one of the big carriers. Like, what's your dream? In 5 years, where are you trying to get them? What do you think great looks like?
Yeah, so I think the first thing that needs to happen is that there's so much belief in your like Blue Cross card here, right? I just call them out because they're the largest carrier. People feel good having that card in their pocket. The employer also feels good giving it to their employees. But what they don't know is that they're giving their employees basically a corporate credit card, and you go spend as much money as you want on it. That's what's happening. And so I think, my dream is first to kind of uninstall that belief and install a belief in like, look, this is the financial world of healthcare, right? These are all the misaligned incentives, and maybe make, 1 or 2 significant interventions like, year one, introduce a transparent pharmacy benefit manager. If the decision makers of that company can see all the misaligned financial incentives and the waste that goes through a PBM, a traditional PBM, like one of the big 3, then I think trust gets built between my position, their company, and then, my dream is that they say, okay, great job with this. You saved us $1 million. Like, go. What else can you do? And so from there, I think it's really building a completely, a new network with an independent, transparent TPA, completely designing a local offering where you can direct contract with everything from surgeries to imaging, to procedures, to behavioral and mental health, introduce an EAP that people actually use. I think nationwide, EAP utilization is like 2 or 3%. And I think it may actually have been an earlier episode of your podcast where I saw someone from Costco, and their EAP utilization is like 20%. And that means right? Yeah, it's amazing. Like that's a helpful EAP. And I don't know if you've ever like called an EAP. I've called an EAP before on behalf of patients, and I personally felt like it was a dead end. Like I couldn't get anywhere. Yeah. And I understand why there's so many barriers to folks seeking care. Or you like meet a therapist and you can have 3 visits, and then now they're not covered by the insurance that your company offers, even though they were covered by the EAP. And so there's like all these kind of broken pieces that are kind of clamped together, like your traditional off-the-shelf plan, your EAP, your PBM, your TPA, and really breaking it all down, eliminating the financial misincentives, and and just really aligning everybody for the best possible outcomes for the people, and do it in a way that's financially responsible and predictable. There's no reason costs need to go up 15% a year. Like, I understand it for the community rated plans on the ACA exchange, but when you're paying the bill as a self-insured employer, like, you need to be laser focused on all your costs and watching them. And again, they should, as you develop more, efficiencies, economies of scale, experience in the space, you should be able to lower prices. That's how every other industry works. And so that's my 5-year dream for an employer, is like, let's make some quick changes so you can understand and appreciate this world, and then let's go nuts and do amazing things for your people and save you money. It's not often that you get to honestly offer something like that. And again, that's what makes me so excited about this space.
That's awesome. That sounds like a health plan that I want to be a part of. And honestly, those are the kinds of plans that we at Milu, when we hear about them, we're like, oh my God, like, we can really have massive, massive impact there.
Yeah, there you go. Right. So like, people in the know get excited about this sort of thing. And so I think that's the path forward. And I hope to be a small part of that solution in our country.
Amazing. Well, Danny, thanks so much for being on. Congrats on all the success that you've had so far, and best of luck with your new endeavor at DHS.
Awesome. Well, Sasha, great to see you, and I appreciate you having me on, and hope to connect again soon.
Take care.
You too.
Thanks for listening to Healthy Savings by Milu Health. If you would like more information about any of the topics you have heard today, we would love for you to get in contact with us. Find us on the web at miluhealth.com.